I want to make tonight fun. So the real take-home message, if there's any, is to give you some insight into how a veterinary practitioner approaches a certain disease entity. I know tonight we're going to be talking about allergies, specifically seasonal allergies. Sounds fairly innocuous, but I want to give you some insight into the different layers that are involved with this disease process. So I want to highlight the variability and the different nuances with this particular disease, because it's easy to recognize the disease, but it's difficult to deal with treating these cases because there's a variety of different clinical presentations. So if we just settle on a particular protocol that treats seasonal allergy, oftentimes we're going to fall short in really achieving the optimal comfort and quality for our patients. So there's a thought process involved with it. It seems very random. I know some of my clients that see me wonder why Dr. Macina is giving my patients so many different meds. But I just want you to know that everything that we do as far as a treatment protocol is carefully thought out based on the patient, the clinical signs of that patient, and the disease entity. So there's really no two allergic patients that I see that are going to go home with the same therapy because there's variation and variability in the clinical signs. And we'll highlight all of that. We'll talk about species variation, environmental variations, individual genetic variation, and certainly a lot of that's going to dictate how we go about treating a patient. So it's not just, okay, we're going to look at what the disease is and we're going to do X, Y, and Z for every single case that we see, because it's not going to lead to the best result that we can. So I want to start out making it a little fun. It's going to be a little confusing. Like, you're going to be like, what's this guy talking about? I'm going to ask for a little audience participation. Who here in the audience wants to tell me what they see in this particular slide? Don't be bashful. Trees. Okay, trees. The Eiffel Tower, right. You kind of get a sense of the time of year. That's kind of an impressionist interpretation or representation of the Eiffel Tower. And even though the Eiffel Tower is in the background, it's kind of the centerpiece of this particular portrait. And the portrait's very inviting. It's very colorful. We could kind of discern what time of year it is. There's some trees that have leaves falling, other trees that have leaves changing color. But the portrait invites us in. It's a portrait of the Eiffel Tower, but it's very welcoming. It's a very warm and fuzzy portrait. It kind of makes you want to be part of the scenery there. Okay, so portrait of the Eiffel Tower. Thank you. Now, what do you see in this? Not a trick question, but it's the Eiffel Tower. But it looks a lot different, right? Obviously, the textures are different. The colors are different. It's much more angular. It's a little bit more austere. It's not as welcoming, yet it highlights the iconic structure that is the Eiffel Tower. But obviously, this representation of the Eiffel Tower is a lot different than the previous one. We know it's the Eiffel Tower, right, by looking at the portrait, but there's a little variation in the presentation of it. So it gives us, who are viewing it, a different feel, a different interpretation of what they're seeing. This is a more contemporary viewpoint, right? We have the classic in the midst of modernity. You can basically interpret it as you see fit, and that's the beauty of art. There's variability, there's different color palettes, there's different brush strokes, there's variability. It's the Eiffel Tower, but it looks different. All right, Going to ask another question of you. How many here, I know this is going to sound confusing, how many here like to cook? Okay, got a good amount of people here. We have a foodie crowd. Awesome. How many here enjoy baking? Okay. Can anyone tell me if you were buying a cookbook or following a recipe, what the major difference is between following a baking recipe versus, a recipe for coq au vin? Yes. What's that?
Baking is exact.
Exactly. You need to follow the script, right, to the letter. If it says a 1/4 teaspoon of salt, or 1/2 of a teaspoon of vanilla, or 1/8 of a teaspoon of baking soda, you better make sure you're measuring it exactly, because if you go rogue and try to give it your own spin, the cake's going to become a disaster, or the souffle will collapse, right? It's very exact. It's a precise science. Baking's like chemistry. Has anyone taken chemistry here? Okay, wow, this is a good crowd. Do you remember your old, whether high school or college, titration experiments? How tedious they were. You had to follow everything exactly, measure everything exactly, be very precise to find the titration point, because if you weren't, you'd miss it, and then you'd have to do the whole thing all over again. So baking is very scientific. With baking, we want to follow a specific script. Is that the same with cooking? No. With cooking, we can add our own signature, right? A pinch of this, a dash of that. You read a cookbook, it gives you some measurements, but it usually says salt and pepper to taste, right? So you can add your own signature to it, which is what most famous chefs do. Mario Batali, Jacques Pepin, right? We know some of the famous ones. They put their own spin on some traditional things. So there's more license to be creative, right? So we may be dealing with the dish coq au vin, but each chef is going to have a different interpretation of what that is. There'll be a different texture to the outcome, different flavoring. So even though we could recognize the dish for what it is, there'll be a different representation of it, much like the artwork. So that kind of is how I approach this. Sounds bizarre. It shows that I was a liberal arts major, not a science major, but kind of is how I look at things. I look at things not by looking at a specific formula, because I can't do it with the diseases I see, right? There are specific outlines of therapy that I can follow, but because of the variability within the disease process and the variability within the patient, I have to be creative, right? So this next quote is one of my favorite. It's by Wolfgang Puck. And it is about cooking, but this is not a cooking lecture. But cooking is like painting or writing a song. Just as there are so many notes or colors, there are so many flavors. It's how you combine them that sets you apart. So I try to aspire to this every day with practicing dermatology, because I have to think outside the box a lot of times. Because if I'm following a set formula for environmental allergy, sometimes I'm going to miss the forest through the trees. And I may provide some relief for a patient, but not the relief that is optimal. So you have to think, use your color palette, think about the clinical presentations and the variation, and decide what compounds, what pharmaceuticals I want to put for this specific presentation of this disease process. So it's not random, it's based on the individual patient. And there's no two patients that are the same. So when we talk about seasonal allergy, what time of year are we at right now? We're in the fall, right? What did we used to call this time of year, if you think back to antihistamine commercials? What's that? Autumn. But hay fever season, right? And what's usually the classic hay fever sign in a human being? Sneezing, runny nose, itchy, watery eyes. If you're severe enough allergic, maybe asthma. So that's typically a respiratory presentation for the most part in a human. Does a dog present that way? For those of my clients here that have canine patients with allergies, do dogs typically have respiratory issues? No. They typically get itchy skin, and they'll get secondary infections in the skin, secondary ear infections. So there's a species variation. It's the same disease. It's the Eiffel Tower, but it's represented different in different species. How about our cat owners here? Does a cat necessarily act like a dog with allergy?
I don't have a dog.
Well, you speak for the... Okay. But is your cat just constantly scratching and
A little bit.
licking,
Not sneezing.
more compulsive licking? Cats are a little different. They kind of manifest allergy by reaction patterns in their skin. Hives are kind of an example of a reaction pattern. Cats can get what we call miliary crusts. They can get more severe lesions that are raised, ulcerative, very itchy, called eosinophilic plaques. They can get little lumpy bumpies called eosinophilic granulomas. But that's how the majority of cats present with allergy. Although some cats are a little bit like us, because we tend to see more of a respiratory component in cats than dogs. That's not to say dogs don't sneeze and get runny nose and itchy eyes. They typically don't get asthma. But we see more cases of rhinitis, inflammation in the nasal passages in cats. And cats like us with allergies can develop asthma. We don't recognize asthma in the canine, but we recognize it in the feline. So the take-home message there is you have to be mindful of the species that you're dealing with. You have to recognize the disease, but also recognize that the disease for this feline patient is different from that canine patient, right? So there's variation, there's nuance, there's variability in it. So we're not going to treat necessarily a cat with seasonal allergy or year-round allergy as we would a dog. The pharmaceutical compounds are going to be different based on the particular species' clinical signs. So, species variation. There's variation within the individual patient themselves, right? Each of us has our own genetic code. So our individual genetics oftentimes are going to dictate how we respond to certain antigens or allergens. How hypersensitized is our particular immune system to what's in the environment? And just to clarify, since we're talking about seasonal allergy, just by the sheer fact that we're saying seasonal, it basically points towards environmental. It's a condition we call atopy or atopic dermatitis. If you have a pet that has a seasonal recurrence of allergic signs, the first thing that we do is not going to change the food, right? Because it's less likely to be food allergic if it's flaring during a particular season, unless you're varying your pet's diet, like a restaurant during different seasons. But typically when there's seasonality, it's going to be environmental. So when we talk about seasonal allergy, atopy, environmental allergy, we're all talking about the same thing, okay? And a lot of seasonal patients can, with time, become year-round. There's also variability with the environment. The reason why certain times a year are worse than others for particular individuals is because of why? The allergen burden varies, right? Certain times a year, you're going to have certain pollens around. Even your indoor allergens are going to vary as well. Your molds, right? Everyone has microscopic mold in their place. Everyone has dust and dust mite, even in homes that pass the white glove test. They're around in the environment at all times. Storage mites.
but the burden of allergen is going to fluctuate seasonally. So when we talk about seasonal allergy, especially if we're talking about the autumn or the fall, hay fever season, it's the time of year where we have lots of weed pollens blooming. Goldenrod, ragweed, pigweed. Okay, so if you have a patient flaring this particular time of year, more often than not, it's going to have weed pollen allergies. The mold counts could also fluctuate though, right? As the daylight shortens and the weather cools down, although you wouldn't know it for the past week, although today maybe. But the burden of environmental mold is going to change. That's why the weather people talk about mold count, pollen count. Your indoor burden is going to vary. As you start to turn the heat on, as it gets cooler, you're going to kick up more dust and dust mite. So you're going to have a seasonal variation in allergy burden, and allergic reactions are dependent on burden and patient's particular threshold to that burden. So again, the challenge for what I do is the variability. And I have to adapt what I know and what compounds I use and take into account that variability. Because if I'm just following a recipe for a chocolate layer cake, I'm not going to be able to treat or produce a strawberry shortcake, right? So I have to vary things accordingly. There will be some scary slides here. You don't have to worry about the minutia. I add the slides to show you the range of different therapies that are available to combat some of the common clinical signs that we see with allergy. So we'll talk a little bit about some of the immunologic things that are taking place and why allergies occur. And then we'll talk about some of the therapies. As Dr. Goldstein alluded to, the old days we used to just use steroids, corticosteroids. There's nothing wrong with them, so I don't want to condemn anyone that uses them. I do use them myself. I see lots of autoimmune and immune-mediated skin conditions. We need to use corticosteroids in a lot of those cases. We sometimes have to use corticosteroids in some allergic patients. But we don't want to use them as the maintenance therapy. You know, we can use them with an allergic patient maybe to put out a fire. But if we start overusing them, we're going to start running into other problems. And the last thing that we want to run into as a clinician is create problems that aren't there to solve problems that you're seeing. So you have to keep the entire patient in mind. A patient with a heart murmur, we're going to be very reluctant, especially if it's a cat, to just pump it with corticosteroids, right? Because it could induce potential heart failure. So you have to be very cautious. And again, that goes back to variation in the individual patient. If I ignore the 4 out of 6 heart murmur, the potential cardiomyopathy, and I come along and say, I'm going to give you a cat an injection of Depomedrol, it will last in the system for 3 weeks, your cat will be great. If I forgot that it had a heart murmur, well, that kitty cat in a couple of days may come in heart failure, right? So there's a lot of factors, there's a lot of variables, and there's a variability in the disease itself. So we can't pigeonhole it. You know, we can't, put square pegs in round holes sometimes. We've got to be adaptable and pliable to what we're seeing. So we'll give you a brief overview. I'm going to highlight some of the more recent things that we found within the last maybe 5 to 7 years. We've made some breakthroughs. There are newer therapies that are available that I know a lot of you have heard about. I'll tell you the pros and cons and when and where to use them, because some of these newer therapies are not necessarily things that we can use just for every single allergic patient, because in certain instances they're not going to do anything if the presentation's a little bit different, okay? And that's going to depend on the variation in clinical signs and the variation in the species and the individual patient. So when we talk about atopic dermatitis, that's a synonym for environmental allergy. So just like us, dogs and cats can develop allergies to things in the environment, right? Seasonal pollens, dust mite, various mold species, human dander, just like we can develop allergies to dog and cat dander, they can become allergic to human dander. I used to walk into exam rooms if we allergy tested a pet and they tested positive for human dander. I used to look at the pet and say, you need to get rid of your owner. But we know that's not feasible. So we need to take that all into account. So when we're talking about atopic dermatitis, we mentioned the environmental factors, the variation and the fluctuation in allergen. There's also skin barrier issues. Like the frontline allergic patients, pretty easy. You know, you kind of quiet down, put out the fire, they do okay. The 8-year-old pet that's been dealing with environmental allergies and flaring and been on corticosteroids long term and constantly dealing with recurrent infections, their skin barrier is going to be different than the first frontline case with allergy. And the reason for that is there is a layer or a portion of the skin, we call it the lipid layer, lipid being fat, right? The lipid layer is we call it the barrier, the skin barrier. With chronic inflammation, the lipid layer starts to break down. So to use an analogy, you think of bricks and mortar, right? When mortar starts to get old, it starts to crumble and crack, and what happens? The bricks become leaky, and you start getting leaks in your ceiling, and you have to call like a roofer, and they have to come, they have to point the bricks, repair the mortar, so that they're not susceptible to absorbing, you know, different water and moisture factors, microbes, and so on. So skin barrier is something that we ignored for many years. We're starting to pay more attention to it. And I'll point out some things that I think we should be looking at in the near future that may even be much more specific. One of the things that you'll notice is as we've progressed in our knowledge with different pharmaceuticals and the disease, the therapies have become much more targeted and specific. So instead of just wiping out the whole inflammatory arm of the immune system with a corticosteroid, we're instead picking out little parts of the cycle and picking them off to downregulate the cycle. Because when the cycle gets going and it picks up steam, it's very hard to break the cycle. It's like a whirling dervish. But instead of just wiping the whole immune system out, if we can block certain parts of the cycle, we can downregulate the inflammatory cascade. And that's where a lot of the focus is. And that's why we kind of choose some of the things we choose. And of course, we mentioned immunologic phenomena. We're going to talk a little bit, we're not going to get too detailed. This is not rocket science. This is pretty easily understood. So what's the most common thing as an allergic person? What would you have an allergic reaction, what are you going to pull off the shelf or go buy most of the time? What's that? Antihistamines, right. The majority of antihistamines are not going to combat itchiness in a dog or cat. They may help with a respiratory presentation of allergy, but they're going to provide little relief. Now, histamine happens to be a neurotransmitter, and it basically is incited by the allergic reaction, and it feeds into the whole inflammatory cycle. Okay, it's going to stimulate and help to stimulate the itch reflex and so on and so forth. And it will help contribute to the perpetuation of the cycle. But histamine is just one tiny component. We used to have a very simplistic view of allergy, right? We talked about mast cells breaking down. Mast cells are cells found throughout the body in the skin and the intestines and the respiratory tract. They break down, they release histamine. You get an allergic reaction. It's a little bit more complicated than that. And though the mast cells play a role, they're not the major player in the allergic reaction. The major player are T lymphocytes. And T lymphocytes, they're good guys, right? We need T lymphocytes to protect us from the elements. But there are situations where they do too good a job. And we have to maybe choose to police their numbers and quell their effect because they're contributing to the allergic reaction perpetuating. So when we talk about inflammatory neurotransmitters, histamine and serotonin are neurotransmitters. A lot of people don't think of serotonin as being part of an allergic reaction, but it is, and it helps contribute to the neurogenic itch reflex. So when we prescribe tricyclic antidepressants, not serotonin reuptake inhibitors, we're talking tricyclic antidepressants, we're prescribing them because they're serotonin blockers, but all of your tricyclic antidepressants are also non-selective histamine blockers. So we can address two birds with one stone. With a drug like adoxepin and nortriptyline and amitriptyline, we can cancel out the action of both histamine and serotonin with one medication. And serotonin plays a role. People are often confused because they go home, they look at the internet, and they're like, why is this guy putting my dog on an antidepressant or my cat on an antidepressant? And speaking of cats, and speaking of degranulating or mast cells that break down, they're going to actually release more serotonin than histamine. So, and that may be one of the factors as to why we see much more psychogenic compulsion in cats than we do in a lot of dogs. So histamine, serotonin, and then a third category called inflammatory cytokines. There's one major one called IL-31. That's the cytokine that stimulates the neurogenic itch reflex. So some of the recent breakthroughs have centered around blocking the action of this one inflammatory mediator. And there are various other leukotrienes, tumor necrosis factor alpha, interleukin 1, interleukin 4. They're all contributory to the whole inflammatory cascade. So I mentioned to you the barrier function of the skin, right? I told you for years it was ignored. But this basically is the outpost of the whole immune system. And this is really what initiates the whole allergic reaction. So within the skin, the outermost layer of your skin, you have cells which we call dendritic cells. And they're called Langerhans cells. There are other dendritic cells, but Langerhans cells are the major ones. And they act as allergen they capture allergen. So they're going to have receptor sites on their surface. Allergen that's getting percutaneous absorbed through the skin is going to be facilitated by these Langerhans cells. So the Langerhans cells basically trap the antigen or allergen, and then they're going to walk up to the T lymphocytes, the resting T lymphocytes, and present the antigen to them. And then the T lymphocytes are going to react to that foreign antigen by producing various inflammatory cytokines. And once that starts, the whole inflammatory cascade gets going. The patient either starts licking, chewing, or becomes inflamed. And the longer that happens, the more inflammatory cytokine release, and the more upregulated the problem becomes. So it could be very difficult. But the Langerhans cells are facilitators. They're the allergen or antigen presenting cells. So those are the cells that are going to sensitize the immune system to the environmental allergens. Now in a human, the respiratory tract, as I mentioned, is kind of the target organ. It's mainly an inhalant disease. We call seasonal allergies or just allergies in general, environmental allergies, as allergic inhalant disease. That certainly can occur in dogs, more likely to occur in cats, most likely to occur in humans. But since the skin is the major target organ in dogs, most of these antigens are percutaneously absorbed through the skin. So that's facilitated by the Langerhans cells. And this is a electron micrograph of what Langerhans cells are. So they capture on their surface the antigen. They present it to the T lymphocytes. The T lymphocytes then stimulate the B lymphocytes. The B lymphocytes then start to produce immunoglobulin to that antigen. That antigen then binds to mast cells. The mast cells break down. They release histamine, serotonin, other inflammatory cytokines. There are other cells in the body due to the inflammatory cytokine release that get attracted into the affected area, eosinophils. Those are kind of the cells of allergy. They will produce more proteases and cytokines. And with time, the skin cells themselves start to produce proteases and more inflammatory cytokines. And it just becomes, as I said, a non-ending cycle of inflammation, itchiness, frustration on the client's part, and a lot of misery on the allergic patient's part. So this is just a little simple schematic of what I've been talking about. It's a simple view. These little dots here represent the allergen that's floating around. And this is your Langerhans cell. These little triangles on the surface, they represent the receptor sites that attract the antigen, which then binds to the surface of these receptor sites. And then at the level of the lymph node, that antigen is going to be presented to your T lymphocytes, which will in turn stimulate your B lymphocytes, and the plasma cells, which are activated B lymphocytes, will start to produce lots of immunoglobulin E. I'll call it IgE. To remember it, think of it as IG evil. I didn't make it up, but just remember that. IgE is an ignition key. Once it's produced, it binds to the surface of the mast cells. The mast cell surface starts to break down. We call it degranulate. And you start to get more inflammatory cytokine release, neurotransmitter release, and more stimulation. And before you know it, I'll show you another graphic later on, this becomes a never-ending cycle. All initiated by these little innocent cells just doing their job, right? Because if we didn't have Langerhans cells, we would be susceptible to microbes, to viral infections, bacterial infections, fungal infections. So they're doing their job. They're capturing, right, the antigen and alerting the immune system. Hey, we got this foreign allergen on board. We got to do something about it. And then the T lymphocytes in kind jump in and they start doing their job. And sometimes they start really doing their job, right? And it becomes a problem where we have to quiet them down and police them. Now, where I think the future may lie and what we're working towards, we're working towards enhancing the skin barrier. But I think ultimately, if we could selectively shut off these receptor sites on the Langerhans cells, because we don't want to turn off all their receptor sites, right, for obvious reasons. But if we can turn those off to specific antigen or allergen, we can even be more specific in our approach and almost nip the whole problem in the bud. We're just not there yet, but we're working towards it. And I'm hopeful that, in the coming years, especially since we've made some major progress within the last 5, I think that things like that are on the horizon in the not too distant future. This is just a schematic. It shows you this is like all schematics and representations of the skin barrier or the lipid layer. You can see how simplistic a view we had, really even to 1985. This is the antigen. These are your dendritic cells. These are T lymphocytes. But you can see how we've progressed in our understanding, and we've recognized more and more cells involved with it, right? So there are Langerhans cells. There are other dendritic cells that start to contribute as well. And there's effector T cells, regulatory T cells, mast cells, eosinophils, keratinocytes, all taking part in this cascade. So, when we're dealing with our treatment choices, we've got to immediately think of the particular patient, right? What the clinical presentation is. If it's respiratory only, we may be using histamine blockers. There's no harm in doing that. But if it's different, we have red, inflamed skin, infected skin, a patient that's chewing, mutilating itself to the point of bleeding, we may need more than just this, right? So we could do histamine blockers. We can do the tricyclic antidepressants, which are serotonin and histamine blockers, because those are helpful. I've used them for years. If any of you have had patients that have seen me, you know I use a lot of doxepin and nortriptyline and amitriptyline and so on. And then there's also agents that inhibit cytokines and leukotrienes, and I'll point out some of those to you. Again, you don't have to remember the minutia, but what I do want you to appreciate is the options that are available and the fact that we're choosing things not randomly. Okay, there's a specific reason why we choose a particular agent or a combination of agents to basically combat that clinical disease. There's T-cell reducers. I know some of you have heard of T-cell reducers. Cyclosporin, an example of a T-cell reducer. Cellcept, mycophenolate, if any of you have had experience with that. There's also Janus kinase enzyme inhibitors, some of the newer therapies to block the itch reflex, block Janus kinase enzyme pathways. Apoquel, oclacitinib, those are examples of that which we'll show later. But again, we can't choose them all, but we're going to select from the color palette what we think is going to best treat the clinical presentation of that particular patient of that time. So we're going to use our color palette, we're going to alter our brush stroke, and we're going to create a protocol that's tailor-made for the individual patient. I'm not going to follow a recipe that is maybe going to help maybe a quarter or a third of the clinical signs. We want to address every clinical sign. And I think you could take the mystery out of a lot of disease that way. If you're in a position where you can break down the clinical signs and assign a compound that can address those clinical signs, you're going to solve a lot of problems, even if you can't put an exact label on it. So that's just food for thought. That's what I teach interns. Don't get bogged down in, I don't know what this is, why don't you just break it down and think about what's happening, right? What are the what's the history? What's the patient telling you, right? Always listen to the patient. And always listen to the client. That's rule number one, because the client knows their pet better than the clinician that's examining it in the exam. They know the history. They know what they've been through. They know what they've tried. They know what works, and they certainly know what doesn't work. So that's valuable in trying to come up with a treatment protocol. We need that history to kind of give us that diagnostic direction, and then our physical examination, our expertise, our experience, basically will dictate the rest in the therapy. And then it becomes a team effort. You have clients, thank you, you helped my pet, and I appreciate that. My response is, I gave you the game plan, but you're the one that executed it. You could have the best game plan in the world. If it's not executed, it's not going to work. So it's a dynamic, it's a team effort. That's why we rely on feedback. How's the patient doing? It's not doing well. Okay, well, it's only a week, so maybe we'll give this a little bit more time. It's 3 weeks already, maybe we need to make some changes, right? We don't want to wait till the recheck and then decide that we're going to make changes, and then the patient is suffering longer than they have to. Again, it's not an exact science. That's the beauty of it. I mean, everyone likes black and white, right? We have trouble with the grays. But it's the gray that is really the challenge. And that's what is a passion of mine, trying to solve the gray area so that we can provide comfort and relief for our patients. Okay, so the recent emphasis on the lipid layer. So some of you have seen some of the new products, the topical fatty acid ceramides, Duxo, there are various brands out there. Those are basically helping to repair the mortar. Okay, that's all they're doing. They're actually more effective than the systemic fatty acids. I know a lot of people are into fatty acid supplementation. I believe in it. The problem is with allergy, you almost have to dose them 3 times the labeled dose in order for them to be effective in an allergic patient. The problem there is a lot of fatty acids are oil-based. So you start increasing, right, the amount you're giving, and it's going to induce like stomach upset, diarrhea, vomiting, and so on. So I think the topical fatty acids and ceramides are a little bit more effective in repairing the protective barrier. I do use systemic fatty acids. If you're comfortable using them, they're not going to harm anything. You don't want to use them in excess because there could be ramifications, but they have their place. Now, the third category, retinoids. It's a category of medication that is grossly underutilized in veterinary medicine. It really is. And it's a shame. And I'll explain why I think it's underutilized. We've all heard of retinoids, right? Retin-A is a topical retinoid. There are various topical retinoids that people use for acne. A lot of people have heard of Accutane, right, which is an oral retinoid. There are other retinoids as well. Now, Accutane is always in the news, right? It has good and bad press, right? It definitely, in some cases, they think it contributes to suicide and things of that ilk, although there's no firm correlation with that. But I've prescribed Accutane. I've not had any suicidal tendencies in any of my dog or cat patients on it. So I can at least speak for them. Now, the other scary thing about retinoids is in people, they're not as liver friendly. The reason is they're analogs of vitamin A. Vitamin A is a fat-soluble vitamin, and the human liver doesn't really metabolize fat-soluble vitamins well. So if we take too much vitamin A, too much vitamin E, D, or K, we may get liver toxicity from it. So a retinoid is in the family. But in dogs and cats, it's metabolized differently. That is not to say that it can induce liver problems. We've had a couple of cases where we've seen an increase in liver enzymes with certain patients. But for the most part, they're metabolized differently. And we monitor the liver, and we don't see any abnormalities. Now, we are very cautious about giving them to patients with diagnosed liver issues, right? Cholangiohepatitis, chronic active hepatitis, and so on. But I use them a lot. They correct the skin barrier for me. If you have a patient with very thickened, hyperplastic skin, aside from controlling the inflammation, the only other thing that's going to normalize the thickness are retinoids, because they actually help to modulate the rate at which skin cells are maturing. So they'll turn down the maturation, and if we turn down the maturation, we're going to slowly normalize the thickness. And that's important because some of these patients with really thickened skin, especially in certain areas like in between the paws, in the armpits, in the inguinal folds, the lip folds, the perivulvar folds, that causes a lot of problems because things like yeast and bacteria love to live in those skin folds, and they create major issues. And not to mention, thickened skin has a lot of, it's not only hyperplastic, the skin itself, but every glandular structure in the skin is enlarged. So you're getting more sebaceous secretion and more secretion from the other glandular structures. And that provides a nice media, I should say, for yeast and bacteria to grow on. And then we got yeast and bacterial infections set up. And then before you know it, the barrier is really chipped away at even further. Some topical things that help the barrier: glycolic acid, everyone's heard of that. Glycolic acid's a beautiful thing. It helps to follicle flush, exfoliate, but one difference between that and, say, like a salicylic acid or a benzoyl peroxide, it does all of the things that those things do, but it acts as a humectant. It helps skin cells retain water, whereas the others blanch or squelch the water out and over dry. So we make various glycolic acid shampoos. We put lactic acid, hyaluronic acid, aluminum chlorohydrate. These are all agents that can actually promote reepithelialization of some ulcerative and damaged skin. So again, there's so many things that we have in the palette, and we have so much to choose from, that if we're just using the cookbook and the textbook says, okay, this is atopy, you treat it this way, I feel I'm doing my clientele and my patient a disservice. Anyone could look at a recipe and look at the textbook, but I think people come to me for more than that. And I like to give them more than that. So, as I said, it's a process, and it just comes from years of experience. It's not being on some pedestal and I'm better than this person. And it's just working at it, seeing it. Kate Coyne had mentioned we see so many cases here in this hospital, more than the average practitioner is going to see, and sometimes a lifetime. We'll see it in a year. Well, that exposure and that experience is a teaching guide for us. The dynamic in this hospital is great. If I have a patient and I auscult a heart murmur, I can send it downstairs to a cardiologist. If it's neurologic, we have neurologists. And we have a working dynamic within the practitioners. So we don't tunnel vision, even though we may specialize or subspecialize. We try to take a holistic approach so that we're not missing the boat when it comes to treating some of these patients. So we'll mention quickly some of the sequelae to allergy. Obviously, bacterial and yeast infections. Yeast infections are also not diagnosed all the time. You really have to find the yeast, do proper diagnostics to see if they're there. Far too many patients, they come in, they're itchy, they're put on an antibiotic and another agent for the itch. Well, if it's not bacterial, the antibiotic's going to make the yeast infection that you missed worse, right? Because it's going to kill the normal commensal bacteria, and the opportunistic yeast is going to have a field day and create more problems. So you have to look at everything. You can't just assume, oh, it's inflamed, it's bacterial, secondary bacterial infection. It may be a secondary yeast infection. It may be a combination of yeast and bacteria. There are commensal yeast organisms. There are commensal bacterial organisms. Both can cause problems in light of chronic inflammation. So when we recognize a secondary infection, keeping in mind the barrier function and that infection is chipping away at it more, it is important to deal with the secondary infection. If I just help your dog that's itching and I ignore the infection, then that's not going to be a good thing. Your dog's going to continue to scratch, lick, and chew because we need to get rid of the secondary infection. So there are different antimicrobial choices that depend upon the type of infection, which I mentioned, both in the skin and the ears. One of my pet peeves is the mass-produced ear medications, because a new ear medication comes in and the practitioner's apt, hey, we just got this new ear medication and it supposedly works for a lot of ear. So dog has an ear infection, I'm going to use it. Well, you have to know what the antibiotic or antifungal or anti-inflammatory is in that new ear medication, because that may not be appropriate for what's growing in the ear. So the client's going to spend 2 to 3 weeks dumping in this ear medication, and it's not specific to that patient's infection. Not going to work. 3 weeks later, then maybe you decide, oh, I think I'll culture it, or I think I'll run a cytology. You should do that from the beginning. So there are systemic choices, obviously, topical choices. We choose shampoos based on the type of infection. We're going to choose various topical agents based on the type of infection. We're going to choose agents based on the presentation. Is it erosive? Is it ulcerative? Is it just red? Right? Is it thickened? So there's a lot that goes into trying to solve the problem. I just list some of the common histamine blockers that actually have a chance of doing something. Fexofenadine, is Allegra. Loratadine is Claritin. Cetirizine is Zyrtec. Clemistine is Tavist. Hydroxyzine is Atarax. Hydroxyzine, cetirizine, and you've heard of the new Zysil. I need to add it. Zysil is levocetirizine. It's basically a more concentrated cetirizine. So you can dose it at half the dose of cetirizine and get the optimal effect because it's more bioavailable. But in case you've seen Zysil advertised, it's levocetirizine. So these are great drugs for respiratory allergies. They may help a little with itchiness. They do help a lot, especially with cetirizine and hydroxyzine and Zysil, levocetirizine. They help a lot with recurrent hives. We call hives urticaria. They're very good antihistamines for that. So if we have a patient that has recurrent hives, we're going to use some of those agents in the treatment protocol. These are the tricyclics that I commonly use. You guys don't need to know the doses. So don't, like I said, ignore the minutia, but just so you get a feel, doxepin, nortriptyline, amitriptyline. These two are basically the same drug. Amitriptyline is basically an older compound. It's broken down in the liver. It's broken down into nortriptyline. So nortriptyline is more of the active metabolite. It's more bioavailable. I still use a little bit of amitriptyline because it comes in a tiny tablet. So for some small pets, it's better than giving a bigger capsule. So we'll make choices like that. But if we have a dog with a slightly compromised liver, we always want to use the more active metabolite because the older compound is going to require more liver metabolism. And the older compound also causes drowsiness, whereas the two more active metabolites don't. Okay? We do use serotonin reuptake inhibitors. We use them a lot in cats. Everyone here has had the allergic cat that will just lick and lick and lick and lick, and before you know it, they can lick all their fur off. Now, we do recognize primary OCD in cats, but it's a diagnosis of exclusion. Because, yes, cats are, again, they're more like us. I'm just telling you. Right? They get asthma, they get OCD, right? They have more hang-ups. Dogs like, hey, throw something in a meatball of food, I'm fine. Feed me, love me, walk me, we're going to be okay. A cat, you've got to do things more on their term, and they're a little deeper sometimes. But they have a propensity to overgroom. A lot of allergic cats groom all their fur off. So if you're just giving them an agent that helps itch, but you're not giving them something that's going to address the compulsion, guess what? They're going to continue to overgroom. So again, it's not cut and dry. There's various factors and variables that you have to come up with. And in a very compulsive allergic cat, we're going to employ drugs like clomipramine. Fluoxetine is Prozac. Paroxetine's Paxil. We do use trazodone as well. That's kind of in vogue here, especially in this hospital. But any of those are good agents. Like I see a lot of patients given trazodone. Like, give your dog trazodone for the next appointment, so it'll come in a little calmer. But it does help. It takes a while to break the OCD cycle. But if we have an allergic patient that's OCD, we'll use this maybe in conjunction with just a conventional histamine blocker. So we may use like a paroxetine and a Claritin, or a paroxetine and an Allegra. And we could combine them in various forms and fashion, right? Especially getting back to our cat owners. The dog is a lot easier creature to treat than the cat, right? Like a dog, you could kind of fool and conceal. A cat, you throw a pill in a meatball of food, they'll go up, smell it, and walk away, right? And if they by chance taste it and it's bitter, they'll forever associate that food with that taste, and you won't be able to feed them that food ever again. They're creatures of habit and they're survivors. They're street smart, right? They're New Yorkers. Cats are New Yorkers. Dogs are from the Midwest and the West Coast, right? The cat's like, always looking at you, don't look at it in the eye. We have some dogs like that, right? But I'm from New York, so I can say that, right? I've lived in the Midwest, I've lived in the South, but there are variations with the species. So those are some of those examples. Now, leukotriene inhibitors. These are drug names, but some of you may have seen the commercials for Singulair, right, for asthma, rhinitis. That's what montelukast is. And zevirlukast is an older compound. Montelukast is a more active metabolite. It requires less liver metabolism than zevirlukast. It's also a little bit more expensive. And unfortunately, pet owners, you can't use the copay, right? So if we prescribe something, you're paying a pretty good amount for a particular compound. Now, this drug, thankfully, it's gone generic, because the brand name Singulair was cost limiting to some people. But we'll use these for rhinitis. They're very effective for preventing inflammation from coming back. If you have an actively inflamed patient, that's not going to do anything. But if you've controlled and gotten the inflammation into remission, we can put a patient on that, and that will control the recurrence, much like a human with asthma. That's what we use Singulair and Accolade a lot for. So you have the asthmatic attack. Once your asthma is controlled, they'll put you on Singulair or Accolade for a while, and that will prevent a recurrence. So they're inflammatory mediator blockers by blocking leukotriene action. Other inflammatory mediators that I'll talk about, there's tumor necrosis factor alpha. You don't have to know about the numbers and the interleukins. This drug, pentoxifylline, they always had a joke, dermatologists always use the P drug, the P meaning prednisone. Well, this is the P drug I use a lot. And it has a variety of applications. To me, it's also underutilized. I use it for allergic patients, but it can be used for a lot more. So what it is, it's an inflammatory mediator blocker. It blocks the action of these mediators. Tumor necrosis factor alpha is tied into other inflammatory reactions, not just cancer. Because you see tumor, it's involved in cancer as well, and it is beneficial to be on a tumor necrosis factor alpha blocker if you do have cancer. But other blockers like IL-1 and 4, interleukin-1 stimulates the body to produce scar tissue. So what's one of the problems with some of these chronic patients? They develop a lot of fibrosis and scarring, especially like in the ears and in the skin. We can use pentoxifylline to break down scar tissue. It enhances collageноlysis, breaks down scar tissue. It enhances circulation. So if we have an ulcer, ulcers are slow to heal because the blood supply is very compromised, right? If we enhance circulation with pentoxifylline, we can bring about a resolution of the ulcer. So tumor necrosis factor alpha you wouldn't think of, but it's an inflammatory mediator involved in hypertrophic cardiomyopathy in cats. It contributes to cardiac cachexia. So it's a drug that maybe we can use for hypertrophic cardiomyopathy, right? Because it's a tumor necrosis factor alpha blocker. It helps prevent platelet aggregation, which prevents blood clots, and it enhances circulation. Those are all of benefit for patients with heart disease. There are other agents, mast cell stabilizers. We talked about mast cells breaking down, releasing histamine, serotonin, and other leukotrienes. Well, there are agents that we can use to prevent massive mast cell breakdown. Some of these were just in inhalant form. Has anyone heard of a product called nasal crom? It's a nasal spray. Nasal crom is cromolyn. It's sodium cromolyn. It's a mast cell stabilizer. We use that a lot in allergy. If we can stabilize mast cells and prevent more degranulation, we're going to help control the patient. Tranilast is a newer compound. It has other properties. It too breaks down scar tissue. It also is very beneficial for mitral valve scarring in people that have mitral valve disease because it inhibits these transforming growth factor and platelet-derived growth factor, both of which are involved. But we use them in allergies. Tranilast actually inhibits those, but it also is a mast cell stabilizer. So if you have an extremely scarred patient that's allergic, Tranilast is a good choice. We're going to break down scar tissue, and it's going to be one of the therapies to help control the patient without blowing out the immune system. There are T-cell reducers. So you've heard of Atopica. That's cyclosporin. That is a T-cell reducer. Mycophenolate, Cellcept, T-cell reducer. Both of these are used in a variety of ways, organ transplant situations if we want to prevent organ rejection. But we use them in allergy for severe cases, especially when we want to downregulate those T lymphocytes that are overworking, okay, and creating more problems. Some of the newer agents we use, especially in some of these severe, this is more of a cat thing, hypereosinophilic disorder, which we see a lot in severely allergic cats. There's a compound called leflunomide, which was used for rheumatoid arthritis in humans, but it is very good for hypereosinophilic syndrome and myoproliferative disorders. So we'll employ that. I had a cat come in with a giant eosinophilic plaque. It was diabetic. Can't give it cortisone because it's diabetic. So I put it on leflunomide, and in 3 weeks, the plaque was in remission. So again, thinking of the patient, you have to pick and choose based on that particular patient who may have another disease along with its allergy. Tyrosine kinase inhibitors, they are in vogue for cancer now, okay? There are some that we use in veterinary medicine, but there's a drug, imatinib, which is also good for eosinophilic dermatitis and hypereosinophilic syndrome. We have some cats that will develop eosinophilic plaques in the pharyngeal area. It will cause lots of inflammation, almost close the airway down. In cases like that, we'll employ a drug like imatinib, maybe in combination with leflunomide, and get it into remission. So again, like I said, the palette is just unending. You've heard of Apoquel, the new compound. Apoquel is basically an agent that blocks the action of an inflammatory mediator called IL-31. IL-31's sole purpose in life is to stimulate the neurogenic itch reflex. So when the Langerhans cells present the antigen to the T lymphocytes, they start producing IL-31, and then that sends a stimulation to your peripheral sensory nerves, which sends a message to the brain and tells the patient, I'm itchy, let's start licking, chewing, and scratching. So Janus kinase is an enzyme pathway that IL-31 likes to use. So if we can shut that roadway down, we can block the action of IL-31. And that's simply what Apoquel does. That's the brand name. Oclacitinib is the drug name. It doesn't do a good job at reducing inflammation. So if you have a cat with a huge eosinophilic plaque, it's going to be itchy, but this may not be the drug of choice. And that's a little schematic of, remember the simplistic diagram we had? This is just a little bit more involved. Langerhans cell, T lymphocyte, producing IL-31, stimulating the spinal cord and brain, and then the patient starts to scratch, and you'll get all of this inflammatory mediator release, and that's what that's doing. I'm just going to quickly touch on two other things, and then we'll open it up for questions.
I don't think we have time for questions.
We don't have, no questions?
Okay.
Okay.
We can stay afterwards, but we have to let the people go. So.
Okay, do I have time to finish this?
Sure.
Okay. Do you
Promise
want to
me for
leave?
an hour.
Oh, I can go. Okay. All right, so I'm going to just finish it, and then you guys decide what you want to do. Okay? So you've heard of the new injections, right? The Cytopoint. That is an IL-31 blocker. Doesn't block Janus kinase enzyme pathway. It directly binds to IL-31. So again, it's an agent, this monoclonal antibody that targets IL-31 without Janus kinase involvement, because there's some weak correlation in humans with cancer and Janus kinase blockers, not typically established in dogs. But if you want to avoid those, we kind of can offer that. There's no age or concurrent drug contraindication, and it is a much more targeted approach. It binds to IL-31 directly. There's also allergy testing, right? That's a big part of what I do, especially for clients that want to provide a non-drug approach to controlling allergies. Just like a human being is put on allergy shots, we have thousands of patients, dog and cat, that are on allergy shots. So they're hyposensitization injections. We can test them either with skin testing, which we call intradermal allergy testing, or blood testing. The skin testing is much more accurate. The blood testing is accurate, but you have to watch the time of year you draw the blood, otherwise it's not accurate. So if we drew blood in February, we're going to get a false low reading to pollens because pollens aren't out in February. So that's important, whereas skin testing you could do year-round. But basically, in simplest terms, the allergy shots basically enable the patient's immune system to build up a tolerance. So remember I mentioned IG evil? So the immune system is building up immunoglobulin to every antigen that it's sensitized to. What allergy shots do, the science behind it, is by giving the patient allergy shots, we're stimulating the immune system to build up IgG, IG good, to those same antigens. IgG is a competitive antagonist of IgE. If there's circulating IgG, it will sit on the receptor sites and prevent IgE from binding. And if we don't have the ignition key, we're going to get allergic control. So we're basically stimulating the plasma cells to build up IgG. And that's the science behind allergy shots. Just one quick thing on compounding. We do utilize a lot of veterinary compounding, pharmacy compounding, because it's not easy to treat every pet, right? And some of the mass-produced formulations may not be in the right dose ranges or forms that we need. Thankfully, the technology has progressed to a point where we can make things in lipoderm transdermal gels and get good systemic absorption of the agent we put in that gel. So for the very difficult cat patient, we can make serotonin blockers, histamine blockers, cyclosporin, pentoxifylline. We can do it transdermally so that you don't have to give them oral medications, but you can apply it to the inside of the ear flap. The old days, the technology wasn't good and the systemic absorption wasn't good. Nowadays, the technology is such that we can provide very effective therapies in a non-traditional way, which makes your job easier, right? Because anything that we can do as practitioners to enhance compliance is ultimately going to lead to more compliance, and that's ultimately going to benefit the patient. So that's basically it. That's just a review. The take-home message, we're going to apply appropriate pharmacology to the immunology of the particular presentation. We're not going to use a cookbook recipe, but we're going to use our own creative intuition, expertise, come up with protocols that are best able to treat that particular patient. So it's a much more tailor-made approach, not a general approach. and we get much more success dealing with the individual patient than trying to pigeonhole every patient into the same category.
So, thank you so much, Ron. That was an amazing overview.